Thank you so much for that great introduction. It's Sandra and I's distinct pleasure to present to you the hot topics in the ADA Standards of Medical Care in Diabetes. So I'm going to have Sandra pull up those slides and we'll get started with our presentation. And so one of the objectives that we're going to be doing today is to really understand that the American Diabetes Association really has developed these guidelines or standards for approaching persons with diabetes. In addition, they have specific directional and informative resources for those that live and work in the community health settings. So let's talk a little bit on the next slide about some of the incidences or the urgency that we're seeing as diabetes in a crisis. It's almost breathtaking to think that every 21 seconds, someone in the US is diagnosed with the condition of diabetes. Right now, with our current statistics, we're looking at approximately 34 million persons in the US. That's 1 in 11 in terms of population. There's also some additional Archimedes data that indicates that if you were born in the last few years, that there is a 1 in 3 chance of you developing diabetes. So it really is a pandemic and an epidemic that we have here. But it is one that we can be proactive and preventative and reactive to. So the next slide will talk to us about how these individuals that are at risk for diabetes or even have prediabetes, and that's what's so hard about prediabetes, is it is a distinct condition that has, metrics such as A1C, 5.7 or above, but less than 6.4. The glycemic metrics is a little unclear. It's usually in the hundreds or the teens, 110, 115. And what's so staggering is that approximately 84 million Americans have prediabetes, and 90% of them don't even know it. And I often kid having prediabetes, even though we utilize that nomenclature, it's really like being pre-pregnant. It's kind of hard to be pre-pregnant. You're either early pregnant or the different trimesters. And one of the things I want to be very clear about is having the condition of prediabetes. It doesn't guarantee that you will graduate into it, but it's a high likelihood. And so really communicating with individuals, persons, when they have these risk factors or conditions, I think is really the first step that we're going to do in identifying those individuals who are at risk. Because what's the best way to combat a disease state? Don't ever get it in the first place. And so the American Diabetes Association, through the link below at diabetes.org, has a risk test that persons can take either for themselves or others. They have different languages available to facilitate that. And we're seeing movement in this area to identify those individuals at risk because, like I said, we want to be aware. We don't want to be behind. And NHANES data just recently dropped the age recommendation for screening to 35. And so utilize these resources that the ADA provides for identifying those at risk. So let's go to the next slide. So what are some of the factors that are fueling this crisis? Oftentimes I'll hear, people say, oh, it's because of our weight, it's all weight driven. And although, yes, our body is designed to operate in a fairly specific criteria, there are multiple factors that are contributing. Everything from the type of food we eat, the level of our activity, the obesity, which is what I call dysmetabolism. I have my degree in my fellowship in obesity medicine, and I did that because it's part of the three-dimensional concepts of getting the disease. It's not just one issue. And so we want to identify all of those things that contribute to it. In addition, lack of access to adequate health care or insurance to identify yourself ahead of time. What are nutritious foods that the body likes and works? What are the contributors from the biological standpoint of age and genetics and ethnicity? So let's move on to the next bit of information. So as I mentioned earlier, the way to cure diabetes is to prevent it. But at times, we're not able to do that. So we must keep pace with it. its progression. We must keep pace with the individual with it, because we have too many people going on to diabetes hospice with the complications. And we do have tools and resources to help us. Next slide. So diabetes is a public health crisis. It's a pandemic and epidemic, but it's also a disproportionality that affects various ethnic and minority populations. Next slide. You can see here that the rates of diagnosed diabetes vary by race and ethnic groups. You can see on the right-hand side the different percentages, or what we call incidences or rates, of non-Hispanic whites, of Asian Americans, of Hispanic and Latinos, of non-Hispanic Blacks, American Indians, and Alaskan Natives. If we break out each of the different races and ethnic groups, we see even different rates depending on where they come in the different continents, such as Asia and Latin America. And we can see that there is an element of genetics, of expression, of gene activation that makes it individualized, but also culturally driven. And so we must be mindful of it, because there are different criteria associated with each group, different risk factors, and different interventional opportunities. Next slide. Now, if we look at statistics by state, and this is a fascinating little tool that the ADA provides. You can go into the diabetes.org, take a closer look, statistics by state, and you can actually place the state that you reside in. And you can get a sense of that burden. You can get a sense of the permeation, the individuals involved. This can be a tool oftentimes just for information, for advocacy, for organizational groups. And I urge you to utilize it as a tool to help advance the understanding, but more specifically in your neighborhood and your community. Next slide. Despite the increasing number of new therapies for intervention and technologies that we're advancing, our achievement of individualized goals are declining. And so we're seeing that those at their personalized A1C target is starting to go down, despite our awareness and all of the advances that we have made. In addition, if we go to the next graphic, we see that it's this downward trajectory. So next slide. And we're not really keeping pace with it. And so we need to reevaluate what are some of those things. Next slide. In addition, the percentage of people that what we call very out of control, those are with an A1C of greater than 9, which is considered poor control, or those out of target, which are A1Cs greater than 8%, is also increasing. So we're seeing those with poor control going up, those with control going down. Next slide. Next one. So the disruption, we have this need to improve care quality in diabetes. We have all these new treatments and electronic health records and applications and Affordable Care Act and all of the different things that are supposed to help us do what we do better. And so there appears to be something missing. Next slide. Look at this timeline. Insulin is coming up on its 100-year anniversary. I mean, what an amazing invention for this serum that is helpful. And if we click and build this particular slide, we see that as we go through the various years, look at the layers of intervention. Look how long from the first therapies to now where we're at, all the way to the top with SGLT2 inhibitors and technology. We have the advent of the standards of care in 1989. And we see that we have the ongoing recommendations. It's a user guide. It's a manual for this. Now, if we go to the next slide, we see here are the current 2021 guidelines for managing a person with diabetes. It's like a little bit of a roadmap, right? And we identify that person at the top, whether they have heart disease or not, where their A1C target is, what kind of medicines could be considered initial. Do you bear in mind the personal things such as cardiovascular risk factors, hypertension, obesity, age, hypoglycemic risk. And so you see that as you go through the different captions, we can navigate to the therapy, to the target, to these recommendations that we are supported by all of these institutions that come together. And so I urge you to utilize this as a directional aid if you're unsure of how to navigate the care for persons with diabetes. Next slide. But there's something wrong with this whole picture. We've advanced our therapies, our technology. Go ahead and build to the next. We have this decline in persons in control, less than 7. Next, at best, only half of them are achieving the goal. We have the increasing number of patients with very, very poor control. This really has become an unacceptable level of morbidity and mortality. As I've said, it's like we're allowing diabetes to metastasize, and the persons with diabetes are ending up on hospice, despite the fact that we have so many new options available. Next slide. So what's really the root of the problem? The root of the problem is we have something called therapeutic inertia, or what we refer to as TI. And therapeutic inertia is essentially that we know what we should be doing, but something keeps sabotaging it. And there are so many. We all can sit and share stories about that as we're trying to overcome what we call barriers to treatment. We have them as healthcare providers. You have them as community healthcare workers, the patient. Even the insurance company practices therapeutic inertia. So what do we need to do about it? Next slide. We need to identify it. It really is the failure to initiate or intensify or sometimes de-intensify the therapy regimen when a patient's therapeutic goals are not being met. We kind of termed it clinical inertia. It includes the underuse of therapies and interventions known to prevent or delay negative outcomes, including diabetes specialty educational services. That's getting somebody to a certified diabetes educational specialist to go through, to continue with the message. It's the lack of screening and prevention, the risk assessment, preventative measures, and referrals. Next slide. So this tool that is on the American Diabetes Association website was designed for us to try and identify the goals and really start to move the whole therapeutic inertia conundrum. And it goes through accessing key patient characteristics. What's their unique profile? Considering very individualized patient-centered targets. Making a shared decision between the healthcare provider or care coordinator or whatever you serve as a role in team diabetes to make a shared decision where you and the patient are on the same page. We agree with that plan using the SMART goals, and we go forward from there to try and achieve that implementation, make sure they follow up with support and monitoring, and then we review, we agree, and we implement the plan and check back at a very short interval to make sure that we're not allowing too much time to go between our new metric goals and our new care implementation plan. Next slide. So here is one of the resources that you have. Here is the 2021 Standards of Care Guidelines. They can be obtained in a printed form or online form. Next slide. And there is a lovely application, the ADA Standards app.diabetes.org. And it's essentially the 2021 guidelines in an application form with general information, different languages, different ways to identify, intervene, and to overcome therapeutic inertia in the treatment of those persons with diabetes. So I'd like to turn it over to my colleague, Sandra, to talk specifically about resources in your field.
Thank you so much, Dr. Miller. That was great information. So I appreciate you taking the time to review all of that. I will go ahead and go into some of the tools that are available and just some additional information. One of the most helpful tools that the American Diabetes Association has, and that they've recently updated, is the Diabetes Care and Management Plan. And what this does is it really helps clinicians, promotoras, to work with people with diabetes to be able to help them manage diabetes better. So some of these tools are available, and I'll walk through what they look like. They're very, very helpful to really discuss goals and really to set that path, to know when to address issues, when to schedule appointments, and really look for opportunities to help connect the patient to better care. So this is a summary of what the care plan looks like. And this was a tool I used to use in my practice all the time. I called it a jog sheet, but it was really a guide so that we were, the patient and myself were on the same page about what things needed to happen. And you can see here listed are the tests. These are based on the standard of care and the frequency on recommendation. But things like what the A1C is and what the target is and how frequently you should be checking that based on the recommendations, blood pressure, eye exam, foot exam, dental exam. And I definitely like to call out dental because sometimes we either don't address that proactively or we forget. And that's very important to people to have better diabetes control. So this really helps to identify what those goals are and then identify when the target date is to have that follow-up. And that way nothing falls through the cracks, because there are so many things to be keeping track of that this is a tool that really helps to guide you to be able to do that effectively. This is just a continuation. I'm a pharmacist by training, and the medication piece is very important. This is a template to be able to document the current medications, what the dose is, how frequently to take it, and the reason for the individual to be taking it. And then it indicates whether this is a new or a change in medication with a notes area. And this is something to be routinely checking in on, reviewing at every visit if possible, and definitely at every transition of care, because changes could be made. And the last thing we want to do is avoid safety, duplication, any errors. So the medication reconciliation is really a key part of diabetes. And so many patients are taking many medications for diabetes, but then also comorbid conditions associated with diabetes that we're trying to prevent. So that's a key area there. Other areas that that this care plan addresses are things around lifestyle. That always is something that we recommend, no matter what medications an individual is taking. You know, what are the weight loss goals, nutritional targets, physical activity, and then things that are really proactive, like engaging in smoking cessation information. And that's very key. And then some other referral recommendations that are very, very important. And again, I'm going to point out some that are very key here. Behavioral health. That's something that we should be checking in on all the time. How is a person doing? How are they feeling? Because a lot of times, if we find that a person is depressed, it's really hard to set goals on activity or on adherence or on anything if you don't address underlying concerns around depression. So that's something just to make sure that you're proactively doing. Vaccines, I'm going to point that out since vaccines are a hot topic right now with COVID. These are the vaccines that are recommended for people with diabetes, but right now we're also in the midst of vaccinating individuals, and people with diabetes are definitely people that are considered high risk or have a chronic condition. So that's something to, make sure you're talking about, address vaccine hesitancy or address vaccine confidence so people have better outcomes. So these are just some of the referral recommendations area to do that. So this tool is available for you to use, and hopefully you have a copy of records, but then the patient with diabetes also has a copy for their records that you're reconciling together to make sure you're maintaining goals. The ADA has a number of educational materials and information that are shared. They also help with the accreditation standards so that groups can actually receive accreditation and then Medicare reimbursement to do that. But there's a lot of training materials, information that's out there, and I was going to share a few of those as we move through the slides. One group that I was really going to highlight is the value of Promotoras de Salud, or the community health workers. And I can't advocate enough for leveraging these helpful individuals in your practice if you have the ability to do that. because community health workers are really connected with a community and they can help to promote health. And what I love about the promotoras of the community health workers is the trust factor and the fact that they speak the language in the community and they recognize the cultural impacts in the community that can really help leverage meaningful relationships. And I'm going to give you a little bit of a story about my first job. When I was in high school, my first job was actually as a promotora de salud at a federally qualified health center down in Nogales, Arizona, where I grew up. And that was my very first job in high school. They actually called me a teen promotora de salud. And I ended up receiving a scholarship from the federally qualified health center to go into healthcare. So that's how my path was laid out for really appreciating the promotoras and what they did. And then I loved the pharmacy. So I ended up pursuing that and always connected with the value of the promotoras to help. And I always think of my mother as a promotora because every time there's a question about health, she calls me and then I answer the question and then she's the person they trust and she conveys back the information. So she's a local trusted person and she connects people to care. So Dr. Miller already talked a lot about therapeutic inertia, and it's basically trying to do the same thing over and over and expecting different results. And it's really hard when you have a number of barriers to keep trying the same things over and expecting different results if you're not really using different tools or different resources like the promotoras to help. And this is just a graphic that I like to share as a pharmacist. You know, for every 100 prescriptions that are written, only about 50 to 70 are filled at the pharmacy. And of those, only about 48 to 66 are picked up. And only about 25 to 30 of those are taken properly. And then only of 15 to 20 are refilled as prescribed. So you can see with every step, there's less and less adherence. And there's many, many reasons why this happens. It could be things like cost of the medication. It could be things like the person experienced a side effect and now they don't feel comfortable taking it. They think that it was a 1 month dose instead of a continuous dose that they should have been picking up. So there's a number of reasons. So we have to, constantly check in, do the mid-reconciliation, use your tools like your community health workers to understand what some of those issues are within the community or what thoughts are so that you can get a pulse of what's going on and hopefully address these issues to overcome what we call therapeutic inertia and get people to goal and keep them at goal. So I wanted to share some of the really exciting things that are happening with promotoras and community health workers. There's more recognition for the value of community health workers. And now there's been so many recent discussions around social determinants of health and value-based payment models where they are really trying to understand better ways of payers on how to approach people who are the most challenging to approach sometimes. And it could be because of things like language barriers. But what I saw, and even in conversations I've had as recently as this week, there has been more discussion about how to use and leverage local resources to be able to reach those people that are hardest to reach or that we have the most barriers with. And I definitely think the promotoras are getting a lot of positive attention in this regard. And you're starting to see that there's more and more states starting to recognize or work on training or authorizations to allow for CHWs to be part of that healthcare system. So I'm excited about that. These are some of the areas where we've seen a lot of improvement. And this slide is a little bit outdated. It's 2012, but we're starting to see this number grow. A lot of this is still very much the case. So there's a lot of work on infrastructure, on how to establish CHW advisory groups, more scope of practice discussions, more certificate and training programs. And I know Texas and California have been leading the way. And here in Arizona, where I'm located, we have a very strong group of community health workers that get together and work on training and outreach. And really trying to understand what the core skills are for these community health workers to continue to build upon the effective way that they approach reaching people and building trust. And then a key factor in all of this is how do you finance these positions? How do you actually integrate CHWs into team-based care opportunities and actually create opportunities to hire or identify resources to continue to grow the impact that promotoras and community health workers are having within the community. So these are some of the core competencies that have been reviewed by some of these groups about what things that make somebody very effective at being a promotora: communication skills, interprofessional skills, being able to help with service coordination, teaching skills, advocacy. I mean, promotoras fill a lot of different roles, and a lot of it is really building on these and growing these, and then definitely their knowledge base increases as they're being exposed to more and more. But I think the key thing I always remember is the trust. You know, sometimes that's the hardest thing to train. You can't train trust, but you know that if you really trust a person and they're part of your community and they help to engage, that's the biggest asset that comes from that relationship. This is just some new information that's being published out there regarding the frameworks of how community health workers are seen as partners in care with health. And you can see all of these different things being brought together. What we discussed is core competencies, but it's really looking at all the contextual aspects that CHWs bring: culture, language, trusting relationships, and all of the roles that they help to play: planning, teaching, engaging, recruiting individuals, and then helping people really reinforce the healthy behaviors, and then bringing back and building capacity to continue to have this continuous wave of information that continues to build. And one of the great examples that I remember when I was working at El Rio Health Center in Tucson was that I would work with a community health workers, and they would actually recruit patients for participation in the diabetes self-management training classes I had. It was really, excuse me, it was really hard to fill the classes. And with the work with the community health workers, we identified that, you know, what if we held a class in a library? It was a local library, and they literally filled the class because people felt more comfortable coming there. It was an environment that people were already attending. So it was just that relationship with the community health workers that allowed for us to actually create better ways to reach people and to actually communicate with the neighborhood about what was happening, and even collect questions before our classes to answer questions and really know what was going on that week or that month in the neighborhood with things that were happening, so that I could be prepared to better answer the concerns of the community. But that was really because of the relationship with a promotora that allowed for this to happen. This is an article that we published here in Tucson, where we are now partnering with community health workers to provide medication therapy management. And one of the things that I love about this is that I'm a pharmacist by training. I mentioned that earlier, but you don't even think about some of the unique ways you can actually leverage that relationship between the pharmacist and the community health workers. This is a project where we partnered with promotoras out in Yuma, in the Yuma County area in Arizona. And what we did with this is that the promotoras would go into people's homes and would actually review medications in the person's home. And then we would connect with them telephonically to pharmacists to review, answer, address questions, and really be the eyes and ears for the pharmacists that couldn't be out there in the field. And so it was unique partnerships like this that really allowed for us to reach a rural community. And we were able to connect a Spanish-speaking pharmacist to a Spanish-speaking promotora to address a patient who had concerns. And we were able to publish this experience and continue to grow the program. So I bring this up as an example of ways that you can really leverage each other to help each other reach better outcomes. And then most importantly, to make sure patients have the best access to resources that they might have otherwise not even realized were available to them. So the American Diabetes Association has a number of resources for community health workers. And this is the website listed here, professional.diabetes.org/CHW. But they have resources that are specifically designed for community health workers. There's free webinar series that address health disparities. There's different information, different programs for patients. So I encourage you to look at this to see if there's anything that might be of help to you. The resources are specifically designed for CHWs. And as you can see, the different series that are available here just talk about continuing education programs and different availability for different topics that might be of interest. And this content is always building, so it's not stagnant. There's always a lot of new information coming in. And I know Dr. Miller and myself have recently done a series of webinars that they've recorded that are available, also talking on a variety of different projects and programs. And one of them recently was the care plan that I just mentioned earlier in the slides. This is another tool that looks and helps find diabetes self-management and education and support programs within your different geographies. So you can find DSME programs either by state, by zip code, by location, and you can even look for specific finders, like is it a pediatric program? Is there a Spanish language program, telemedicine? So you can really hone down to see if there's anything within the community that you could refer to. And I always like to look up information, especially if I'm finding that as we're talking to patients, if they need extra help, we can actually ask for their zip code and have a local referral to somebody that they can potentially see in person. So ADA is available for membership, and they have a CHW category also. This is new, and it's designed to really help support the promotoras out there, because we know that the promotoras are essential to getting people to goal, especially as we were talking about therapeutic inertia. So this is to help support the CHWs. There's a lot of additional resources. I mentioned earlier the webinars, but there's also other information around food insecurity, nutrition information, and the Diabetes 101 resource guide as well. One of the really great resources that the ADA also offers is a patient education library. They have over 100 different diabetes management and health promotion topics that are listed here. And so the plan your portion, this is a picture of a plate. And I use this tool quite a bit in my practice so that you can help actually have visuals within within your practice, or if you're carrying out there in the field, information that you can quickly access. And this is a really important as you're trying to get the latest information. So things change a lot, but this library is kept up for you. There's also a series called Ask the Expert. It's a monthly live question and answer session. So this is to text, or you can actually register and participate, and they have questions that are happening, different resources that are available. But this is a great resource if you have anything that you need to, get updated on, or if you're hearing something in the community that you can have a local person to actually ask and see what kind of feedback that they give. And then this is the resource around diabetes food, 700 diabetes-friendly recipes. Again, a lot of information around nutritional facts, interactive meal plans, edible shopping lists, cooking tips, and really they're designed to be able to help people with diabetes so that they have a variety, which is good, and then they have a quick interchange or exchange of information so that they're able to be creative with what they're having for nutritional. More information here on additional resources. This is Living with Diabetes. The good thing about this is that this information is available in English and Spanish. There's e-booklets, monthly newsletters, more healthy recipes, and then this is the website to be able to sign in for that. The American Diabetes Association also has a group called Diabetes is Primary. And this group is a group that the ADA put together to actually take the guidelines that were meant to be very inclusive and then make sure that they apply them to primary care. So I actually sit on this group. They take the standards of medical care and then they create an abridged version. And they're really designed to be applied to primary care, to clinics, to be able to look at what things apply to them. So this really reviews the current guidelines, and they're published every year in January. It reviews the latest treatment options. It was the information that Dr. Miller presented with the new standards of care, the tables. The other thing it does is that this group creates numerous materials and content and webinars throughout the year to address different treatment options and to make sure that that information is shared with clinicians out there, with promotoras, and address a lot of the primary care issues that you're seeing. So if I know there's a question that came in around technologies, the new CMG the continuous glucose monitoring, CGM sensors, the new meters, the new tools that are out there. So they help to design and create content to be able to share the latest information on that. This is a website for that group, professionaldiabetes.org, diabetes primary. And this is information on how to become a member. So there are a lot of information around different tools that they have available. One of the ones that's really interesting right now is ADA's COVID-19 resource. There's a frequently asked question information guide there for all the questions that are coming in related to diabetes and COVID. So hopefully you can look that up. It's just really timely information that's being reviewed by experts and looking at whatever new information is coming in. But really, there's new research, landmark studies. There's a lot of opportunities to become a participant in some of the work groups and to help develop some of the content. So I know that there's a lot of people here with very specific backgrounds. Hopefully you would want to be part of this group and join in and share your expertise, because you bring in some very, very valuable information. So with that, this is the last slide that we have. It's just more about diabetes.org and the 1-800 number if you have questions. What we'll do now is Dr. Miller and myself will stop sharing screens and we'll open it up for any questions that are coming in from the participants.
That was great material, Sandra. I loved how you personalized it for those individuals who are in the community health area. You know, you mentioned kind of briefly the question that we saw in the chat about technology, and I know that you and I could probably spend an hour on it, but I think we'll give it a few minutes because it is an emerging area in diabetes management. And so the question surrounded the utilization of diabetes technology in the managing of persons with diabetes. And I have a particular passion for this. I sit on several advisory boards. I also have done a lot of presentations and recent articles about how to integrate technology in your care for persons. And I like to use analogies. You know, we look at the A1C metric. The A1C metric is a retrospective metric, and it is the one we have, and we work as well with it. But oftentimes, you know, knowing your average speed doesn't help you to know if you're speeding or not. And so CGM is really, you know, continuous glucose monitoring is a field of diabetes technology that is really going to bring us out of the past in diabetes interventions to the present and looking at the future, because it's both a present metric and a predictive metric. Now, if we go very specifically into it, there's several different categories, and I would urge you to become familiar with it. So you, as you're interfacing with individuals, so you know what it is, you know what it looks like. In addition, you can encourage them to pursue it, because I believe with even the advent of the Apple Watch that does EKGs and all that stuff, we're going to be seeing, I think, a dawn of an empowerment of persons using technology with diabetes. And so, you know, there is some, but not a large cadre, and some are a little, how shall I say, less barriers for application. We have the Libre, which is in your neck of the woods. It's a pharmacy benefit, right? You're seeing those come over, and others such as Medtronic and Dexcom are generally done through a durable medical, but I've seen that they're starting to, you know, permeate into the pharmacy benefit area. And then we have many of these monitorings with phones. There's also a personal diabetes receiver with it. And then taking beyond that, knowing what you are, it helps you with medication management. It helps you with, how should I say, how life and food and different things impact, right? You get your own little user manual.
Oh yeah, so I wanted just to share this story. My daughter was diagnosed with type 1 diabetes in February of this past year, not last month, but about a year ago. And, you know, I've been managing diabetes for 14, 15 years before that. So to have my own daughter develop type 1 was very, very shocking and stressful and concerning. And as a parent, that's the last thing you want your anybody, but definitely your child to deal with, because you know too much about what could happen. But I can tell you, she's on a continuous glucose monitor. She's on an insulin pump now. And it's just amazing the incredible advancements in her quality of life in being able to maintain control with these tools. In fact, for the first 6 months, she wasn't able to use a CMG because it takes a while before it's approved. And people feel comfortable with that. But she had to poke her finger, do finger sticks and take out blood and do all that. And then we put her on the Libre, which helped a lot. It's such an incredible advancement not to have to poke yourself all the time. And then we put her on the sensor that now checks her blood sugar like every few minutes, continuously, all day, 24/7. She plays tennis. It tells her if she's going down right before bed. It tells her if she's going to go down or up. And then it actually self-adjusts. The pump self-adjusts to lower insulin or to, help her give extra dose, calculate. And I can tell you the difference even in those few months of having to poke yourself to having more readily available information to having a continuous glucose monitor have been transformational, and makes it not completely better because you still have to live with a condition, but her quality of life is much, much better. And I can at least go to bed knowing, she's not going to go hypoglycemic. And even if she starts trending down, there's an alert in the middle of the night that wakes us up. So those are things that are built in to at least give you some comfort and hopefully decrease stress. And that's really important. So I see those tools as critical, hopefully more accessible to people so that they can help manage a condition that's very difficult, because it's a 24/7 job. You always have to think about what you eat and what you're doing and your activity and your hormones. And so tools like that, I think, help quality of life more than anything. And there are some bumps in the road. Technology is not perfect, but I would say that if I had to choose that or not, I would definitely choose the technology.
Yeah. And, you bring up a good point because, listening to your story about your daughter, it is so amazing how we live and work in this world, and then it becomes personal. And when it becomes personal, just like myself, I developed type 1 in med school. And so it's part of the passion I have for it. And what is kind of the myth I want to bust out there is that diabetes technology, all persons with diabetes could benefit from it. Oftentimes we think it is either an insulin type of scenario or a prevention of hypoglycemia. We're seeing emerging data of those individuals who are not taking insulin or who are intervening in dietary or lifestyle. We see an improvement in technology with medication adherence and food choices. I call it the engagement or accountability tool. I do think it is on the upswing of adoption. I urge our participants that beyond this webinar, there are several resources in terms of finding how to apply a sensor, how to integrate a sensor, how to get it covered, how to do different, we're having now Bluetooth connected insulin pens. Many of you may not be aware of that we have delivery devices in a pen form for insulin that will mark up continuous glucose monitoring reports. They will record it in a phone app. And so if you familiarize yourself with this, and you could then, when the person comes to you, you can say, oh, I have a tool for you that I think might do a need. And so don't limit the technology in your head, explore it, understand it, know the different ones that are there. And like I said, there are many different resources to help with its application. One last statement regarding that, and we'll open it up for more questions as well, is I just was on a advisory board about an hour this morning. It was through Stanford University. It is called DiabetesWise. And DiabetesWise is a technology platform decision aid for both persons with diabetes and providers. I think they actually are kids, because Sandra, you and I are getting older, and these young tech people are developing an application where you go in and you're introduced to all the different technologies, what kind of diabetes you have, both from the patient and provider. And not only that, they tell you how to prescribe it, how to get it filled. They even embed, Sandra's going to be like, I want to know that site, because they also have the Medicare and Medicaid forms built in. She's writing it down right now, and those forms pop up. And so this is about therapeutic inertia, you guys. We can know something, we can see a need in our person, and we want to be able to acquire that information and that stuff for them. We could have the greatest of intent, and then it gets derailed. It gets a pothole. And so that's why we all are a team. And how, as a physician, I'm not any different than every member of that team. And I love how you brought up the dental. On Friday, I'm doing a presentation with the American Dental Association with a periodontist of how the mouth involves. So I know that there are other questions. We still have a little bit of time. You can ask us pretty much anything related to diabetes. And so if you have anything, please, just place it in the chat box, because we want this to be meaningful for you. We had some specific material we wanted to show you with the ADA. Even as I'm reading it, and Sandra and I are both involved with it, I was reminded, I got to get that plate thing. I got to download that, because we are practitioners in our own right, and we're still always looking, for ways to intervene. And if we all have a similar message and we're all enforcing each other, not one of us has to do all the work. We can all share it, and we can all include. And then when the person sees you and me, they're going to go, wait a minute, they said the same thing, or they said, I probably better work on that. So
you'll have to put the website for that research you were talking about, because I want to look it up.
Yeah, diabeteswise.org. I see another question here about the dental offices. So Cutting Edge this Friday is our first marrying diabetes in the mouth. They call them the mouth physicians and the diabetes physicians. Let's see, I don't know how much I can tell you. There's really a lot of movement right now. There is a CDC advisory board, as well as the Centers for Medicaid and Medicare, to consider covering dental evaluations for persons with diabetes. Don't go run out there and do it. It's not there yet. But the question was, what about regular dental checkups? Imagine your whole body is healthy with diabetes and your mouth is terrible. We are also working with them, that Sandra would be interested in this. They are actually biomarkers in the mouth with saliva that can predict if you're at risk for developing diabetes, or also determine your control. And while we were meeting, I said, hey, do you know if glucose changes in the saliva based on your blood sugar? And they were all, we don't know. And so we actually went and checked. But as a person living with diabetes, I would say, yes, it does. You can feel it, right? But we actually looked, and there was a study out of India that your serum glucose is mirrored in your mouth. And, imagine an area of your body that's not attended to, that's just getting the ravages of diabetes. And so I liked how you brought that up, Sandra, about the dental health. It was a good.
Well, one of the programs we did here at the FQHC was another interesting partnership, like we did pharmacists and promotoras. We did pharmacists and dental, where we would have a collaboration. So the pharmacists were doing intensive management of people with diabetes, but we could only get people to goal so much, because if people had periodontal disease or anything going on, it was really hard to get to goal, because you had pain in the mouth because of tooth problems, periodontal disease, or like a chronic form of infection going on. And so we ended up working with the dental hygienist to do very deep cleanings and actually address the health of the mouth. And then we actually saw the person who was not at goal get to goal. So it was that partnership between intense intense diabetes management and then intense dental management combined together that actually got people to goal even better.
Yeah.
So that's where I think you really have to think about dental all the time, and not just, as only when you have pain, because at that point it's not prevention, right? But it's hard to get in if you don't have dental coverage. So we have to figure out better ways of making sure that there is coverage. And at the end of the day, we see better outcomes if we do those partnerships together.
Absolutely. We check people's feet, right? We want to make sure they're not developing pre-ulcerative calluses. We need to check them out. And in my workings with this institution, it's the first time I've worked with a dental association for the United States. They said, do you know, if you treat periodontal disease just from a standpoint of the cleaning, said your A1C can improve by 0.6. And I said, you're kidding me. That's independent of medication adjustment or intervention. It's really getting the mouth healthier, which kind of brings up what we talked about at the beginning. This is a 3-dimensional disease. It is not just a sugar problem. Sugar is the mascot of diabetes. I'm not saying it's not important, but to just call it a sugar problem, it's really a total body problem. And if we treat the body, but we lose an area, and many of the committees that are going forward that Sandra and I are involved in are really looking at the whole person, the cardio-renal, metabolic, cardiovascular, the mental health component, you're this healthy organism. And it might seem overwhelming, but it actually is an opportunity for the shared goals as each of us have our little silos of specialty. And so that's why we wanted to highlight the community health workers, because we're really, all in this together, and that we all are putting our piece into that puzzle. Because some of the issues with diabetes is it's a long-term problem that just doesn't end your life quick enough. And that sounds very morbid, but the reality is it's a lifelong chronic disease management, and it can get tiring, and it really is just that whole body, and we all can have opportunities for it and resources. And I think it's kind of exciting, because we're really gonna move the needle, because we just have to do something. We're getting too many complications.
I agree. Well, and today I put it on the chat. It's Diabetes Alert Day, and it's the day to go out and get yourself screened to see if you're at risk for diabetes. So it for whatever reason, coincidental, it happens to be today. It's the diabetes test. Yeah, it's a very short questionnaire. You don't have to have a blood test or anything. Answer a few questions about your family history, about your activity, your weight, and then it'll give you a score to see if you're at risk. And if you are at risk, it's a matter of trying to work on preventative type of interventions. So hopefully you can delay altogether, or at least prevent it. Not at least prevent it, hopefully prevent it.
So well said. We only have a few minutes left. Any burning questions? There is that survey that we would like you to complete for our organization, so they can make these even better and better as we go. I know for me, this is the first time I've been invited to your party, and I very much appreciate it, and appreciate the work that all of you are doing, because it makes me sleep better at night knowing that we all have this shared journey and adventure together.
And thank you to Ezekiel, who was trying to keep up with us, and we were talking like 100 miles a minute.
I know.
So thank you. Thank you for trying to slow us down.
I really, really tried. You have no idea how slow I'm speaking.
I want to intervene here, and I want to thank you both. It's been so many thoughts came through my head as you were sharing your experiences, both of you. And being a CHW myself, I can associate to different things that you were saying, and how, how difficult it is for people with diabetes to understand the whole concept of head to toe. And that's something that I think that as promotoras and CHWs, we can support your work and work with you as a team and help introduce that concept, because it is incredible how, it's a sugar thing, but it's a body thing. It affects all your body. So I want to thank you both for your time and your great information and your great participation. I don't know if anyone has any comments or questions that wants to add. We have a minute for the presentation to be over. So if nobody has anything else, I'd like you to take a minute to take I added the SurveyMonkey evaluation in the chat. If you want to use that link, please follow it, and thank you for your time.